Welcome to this Edwards Life Sciences webinar presented in collaboration with CTSNet. How low can you go? Should MVR age guidelines be lowered due to better bioprosthetic mitral valve durability? We're glad you could join us. Please note this webinar is being recorded and will be available next Tuesday on ctsnet.org and CTSNet's YouTube channel. At this time, I'm pleased to introduce the moderator for this webinar, Dr. Joanna Chikwi. Dr. Chikwi serves as the chair of the Cardiac Surgery Department in the Schmidt Heart Institute of Cedars-Sinai in Los Angeles, California, in the United States. She's a recognized leader in the field of mitral valve repair and coronary revascularization, with expertise in minimally invasive cardiac surgery. Thank you for joining us, Dr. Chikwi. I'll turn the panel over to you.
Thank you very much, John, and thank you to our audience for taking the time today to explore this important topic. And I am really delighted to introduce three mitral surgeons that I regard as absolute leaders in the field to our audience today. So first off, we have Dr. Matthew Romano, who's an associate professor of cardiac surgery at the University of Michigan in Ann Arbor in the United States. His clinical expertise and interests includes mitral and tricuspid valve repair, minimally invasive surgery, percutaneous and catheter-based mitral and tricuspid valve repair and replacement. Dr. Patrick McCarthy, who I regard his results as really setting one of the standards in mitral valve repair, is the executive director of the Bloom Cardiovascular Institute and the Heather Sachs Professor of Cardiothoracic Surgery at Northwestern University Feinberg School of Medicine in Chicago in the United States. He has received national and international recognition in the fields of complex adult cardiac surgery, including valve repair, replacement, and atrial fibrillation. And then finally, Dr. Stephen Bolling, who is a phenomenal educator that we have really enjoyed working with, both in sort of wet labs across the nation and on multiple webinars with Edwards. He's a professor of cardiac surgery at the University of Michigan in Ann Arbor in the United States. He's received international acclaim for his innovative approach to mitral valve repair in patients with end-stage left ventricular failure and his ability to repair challenging mitral valve abnormalities of almost any pathology. He's always got interesting and perceptive insight to share. So we're going to sort of keep this fairly informal. There will be opportunity between each presentation to ask questions, and you can ask questions at any time using the Zoom Q&A function. That's the little button at the bottom of your screens. We'll generally pick up your questions following each presentation and even answer some of them real time. We're going to have three presentations, and the first one is going to be Dr. Romano's presentation. Should mitral valve replacement age guidelines be lowered due to better bioprosthetic mitral valve durability? Dr. Romano.
Thank you, Joe, for that introduction. I'd like to welcome everybody and thank you for joining. So I'm going to share my screen here. Okay. Bioprosthetic mitral valve replacement, mechanical mitral valve replacement decisions. How do you choose? How low should you go? Here are my disclosures. So let's start off with a hypothetical patient. You have a 55-year-old male with severe MR due to rheumatic mitral valve disease. You decide the echo shows an ejection fraction of 65%. Severe MR, dilated tricuspid annulus, mild TR, and right ventricular systolic pressure of 45. The patient is fairly active, and he enjoys skiing, sailing, hunting, and running, and questionable pre-diabetic with a mildly elevated hemoglobin A1C. So what do you recommend? Well, before we get into that, let's look at what the data what the guidelines recommend. So in the United States, the ACC/AHA guidelines recommend that patients greater than 65 years of age, it is reasonable to choose a bioprosthetic valve over a mechanical valve. Across the pond in Europe, it's a little bit more aggressive. They recommend a bioprosthetic valve for patients age 70 or greater in the mitral position. Well, where do they get these recommendations from? There is limited data and somewhat older data. I wanted to discuss this paper, which is cited in both of these guidelines and is gained a lot of attention. This was a large administrative database out of the state of California, looked at over 15,000 patients that underwent a mitral valve replacement. and both bioprosthetic and mechanical. Interestingly, during the course of this study, the use of bioprosthetic valve increased from 16.8% to almost 54%. The findings of this study concluded that there was significantly higher mortality with receipt of a bioprosthetic valve, and the long-term mortality benefit that was associated with a mechanical prosthesis as compared to a biologic prosthesis persisted until 70 years of age among patients undergoing mitral valve replacement. And what I want you to look at is when you look at these three graphs, one way over here on the left are patients aged 40 to 49 years of age. Surprisingly, in this group, the 30-day mortality was 5.6% if you got a bioprosthetic valve compared to 2.2% of a mechanical valve. And that should tell you something. That is odd finding. So when you dig a little further into this paper, it said the use of a mitral valve prosthesis was associated with significantly lower cumulative incidence of stroke in patients between 50 to 69 years of age, but not in other age group. Also, a stroke or bleeding event during follow-up was a significant risk factor for death, which is not surprising. The use of a mechanical prosthesis was associated with a significantly lower risk of reoperation than was implantation of a biologic valve. However, mechanical valves were associated with a higher risk of bleeding and in some age groups, a stroke. So stroke and bleeding were lower with a bioprosthetic valve, but increased bioprosthetic valve mortality was most likely from reoperations, or there was most likely a matching problem at the groups at baseline. Surprisingly, in those who underwent a reoperation, the mortality rate was 14%, which is incredibly high. So are we missing something with these results? Well, yes, we are. When you look at the PROM, the STS PROM is really good at looking at the middle point of the bell curve, but it doesn't account for things on the far left, such as liver dysfunction, drug and alcohol use, social determinants of health, young females who want to have get pregnant and have children. It doesn't look at frailty, cancer, or even patients in wheelchair. And I've seen patients who come into my clinic who are in a wheelchair and are quadriplegic, and those patients are going to get a bioprosthetic valve. So the patients, I think, are different at baseline. And what about anticoagulation? Well, this is an advertisement for warfarin, which is rat poison. This is a really important paper that Dr. Chickway published out of New York, and it was a large statewide database that found there was no difference in patients undergoing bioprosthetic versus mechanical valves. But what it did find is that there was a significantly higher incidence of stroke in those who underwent a mechanical valve compared to a bioprosthetic valve, 14% compared to 6.8%, so double. And you paid a significant mortality price for that. The mortality for a stroke was 8.5%. Similarly, the incidence of bleeding events were higher in those undergoing a mechanical valve with anticoagulation versus bioprosthetic valve, almost 15% compared to 9%. And again, a high mortality rate of almost 7.5%. The incidence of undergoing reoperation was higher in those with a bioprosthetic valve over a mechanical valve. However, what's important is you didn't pay a penalty for undergoing a reoperation. The reoperative mortality was 5.3%, which is similar to the mortality of the index operation. It was not 14.5%. So what we did in our study is that we wanted to look at the durability of bioprosthetic valves. This was a collaborative retrospective study between two AHA Mitral Foundation reference centers. We looked at a little over 1,500 patients who underwent a mitral valve replacement with a bovine pericardial valve between 2004 and 2020. The four valves we used were the Paramount, Paramount Theon, Magna Mitral, and Magna Mitral Ease. The data were abstracted from the STS Adult Cardiac Surgery Institutional Database and Medical Record Review. Our outcome measures were, in terms of long-term, were the first incidence of a censoring event, which we defined as mitral valve explant, valve-in-valve procedure, VAD, transplant, death, as well as stroke, thromboembolic events, antithrombotic management, functional status, and valve-related events and morbidity. We define structural valve degeneration as a permanent and stringent change through leaflet deterioration or supporting structures per guidelines and by expert adjudication. Our clinical follow-up was median time was 75 months, and echo follow-up was 37 months. Here are the demographics, and what I wanted to especially point your attention to was that about 42% of the patients in our study were outside the guidelines. That is, that they were less than 65 years of age, according to the US guidelines. And here are outcomes. Our 30-day mortality was low at 5.4%. Late endocarditis and late stroke were low. And you can really appreciate that when you annualize it. Life-threatening bleeding and hemorrhage and thromboembolic events were also low. And importantly, valve hemodynamics were pretty good. The late incidence of mitral regurgitation was low, and the gradients of these valves remained respectable at a mean of 6.2. Now, you got to remember that the mechanism of failure for a bovine bioprosthetic valve is different than that of a porcine valve. The onset of structural valve degeneration in these patients are usually slow onset stenosis due to calcific changes. Importantly, the majority of patients have not had a censoring event. And the largest censoring event was non-valve related death at about 36%. When you look at the cumulative incidence of mitral valve reintervention due to structural valve degeneration and accounting for all competing events, what we found was at 10 years, it was only 6.2% for all age groups, separated here by 10-year categories. And similarly, at 15 years, it was only 11.9%. Of those that underwent a reintervention, about half of those patients underwent a valve-in-valve procedure. And when you look at the deciles for those who underwent reintervention, when you look at their overall mortality, it was very low at 5.6%, which is basically the same as the mortality for the index operation. So some of the two critical questions I feel that you need to ask, and we look at this paper, is what is the need for reintervention and what is the risk? Well, the overall need for intervention is about 4.2% in our series. And how about the risk? Well, let's look at this by deciles. If you're in your 70s, you almost don't need an intervention at all at 10 years and 15 years. How about when you compare patients in their 60s to 70s? Well, not that much different, pretty much the same. What about when you compare the 50s and the 60s? Well, that looks pretty good too. Overall, at 10 years and 15 years, pretty constant. You really don't need much of an intervention. And when you combine the 40s, 50s, and 60s, these graphs and lines really aren't changing, and they are all non-significant. I think we're at a point right now when we discuss a patient, we're looking at lifetime management of valve disease. It's a new era for us. And I think what we need to take into consideration is the new technology such as tissue preservation technology and reduction of calcification and long and prolonged durability in bioprosthetic valves. And I think the technology with valve-in-valve is really changing the way we approach patients too. Ultimately, when we make a decision on what to recommend to a patient, it's a shared decision process. And this is a class 1 recommendation. And we would suggest that we remove age as a cutoff in the guidelines. The factors to consider and discuss are comorbidities, the other needs for anticoagulation, age, patient's lifestyle, any anticipated upcoming surgery, such as a potential transplant. And you always have to remember, too, that we don't live with the decision the patient does. They're the one that's going to have to take the anticoagulation and be faced with the reoperation as well. So with that, I'd like to thank you, and I'll be happy to take any questions prior to moving on to the next talk.
Well, thank you very much, Matthew. That was a really helpful overview. And I think before we take questions for the audience, who again, you are very welcome to type your questions in the Q&A, and from our panel, I'd just like to ask you about your choice of the phrase need for intervention, because those were astonishingly low intervention rates, but they don't necessarily reflect need for intervention. And the big advantage that your institutional series has over those JAMA and New England Journal of Medicine papers that you reported is obviously with the large data sets, we've got no idea what the echo finding was on any of those patients with bioprostheses. So at your institutional series, did you have any insight into the prevalence of structural valve deterioration, severe MS, severe MR from bioprosthetic valve failure that perhaps isn't getting reintervention, so doesn't show up in those event curves?
Well, that's a really good question. I think in our institution, we're pretty aggressive with patients coming back to us, and we follow them closely internally and externally. I do not have the percentage that don't get referred that need an intervention. The nice thing about this series is we had really good follow-up, and we looked at the incidence of recurrent MR, which was low, as well as the gradients, which remained low over time. So, that's the best insight I can give you based on our experience.
Hey, Matthew, maybe you can comment on all those big databases that Joe talked about. There was a smattering of this kind of valve and that kind of valve and this kind of valve and that kind of valve. The series that you presented from our place and from Northwestern, they were all basically the same biologic valve. They were all bovine valves. They're basically all magna valves, and they present just with mitral stenosis slowly. They don't really catastrophically present with MR. But this is a first series really of one type of valve of follow-up, and I think that makes comment on it. But I think that probably makes the findings more true or more verifiable.
Yeah, no, I think you're right. And when you look at some of the meta-analysis studies that they've done on bioprosthetic valves, it's, as you mentioned, all different types of manufactured valves, a mix of porcine and bovine. And I think the nice thing about this study is that it is a single type of valve, all bovine bioprosthetic. And I think the advantage, too, of this is that the slow onset of stenosis rather than a catastrophic presentation of regurgitation, as you can see in a porcine valve. So I think that's important to note.
So Matt, you started the case presentation of a 55-year-old who is very active and generally healthy, skiing, all the usual stuff. So in your practice, how often do you do a mechanical valve in a 55-year-old, do you think? And then what would be the indications? Why would why would the patient want to choose a mechanical valve, do you think?
I would say it's exceedingly low that I implant a mechanical valve. I have a really thorough discussion with the patient. Ultimately, it's their decision. I don't really know many patients that I've come across that say, yes, I want to take Coumadin for the rest of my life. Especially in the active patients, that's the last thing they want to be burdened with and potentially changing their lifestyle. And as I ended my talk, I said, the patient is the one who's going to have to live with their decision. And I think that's a driving factor. Patients that I consider strong or would give a little more of a recommendation for mechanicals if they're going to be on Coumadin for the rest of their life anyway. Maybe they have factor V Leiden and they're already on Coumadin indefinitely, or I say atrial fibrillation, but we're also pretty aggressive and have really great long-term results with our antiarrhythmic surgery. So that in and of itself isn't, but if there's a strong reason for them to be on lifelong Coumadin, that would be the reason that I would probably favor a mechanical.
Yeah, I would agree with that. And the other situation is somebody who has a mechanical aortic valve already, like a rheumatic patient that, they're coming in a little bit later. But, those patients aren't all that common. And
No.
patients are not that excited about, the need for long-term Coumadin. And personally, I wouldn't want to have that risk for a stroke every morning when I wake up.
No.
The other thing that's very different about your institutional series compared to those big data set analyses is that you were able to look at transcatheter valve reintervention. So as somebody who's got a huge degree of expertise in that area, what kind of outcomes are you seeing for patients? What patients can you successfully treat with a transcatheter approach? And what are you telling your patients now? And also, how does that change how you implant valves as a surgeon first time around?
Well, I think we're gaining more and more experience. I think the data is still growing to provide long-term, but Northwestern is in the midst of publishing their data. They basically have no mortality at 1 year in the valve, and Pat can comment on that a little bit more. I think what's important when in considering the new era is to do everything you can to implant the largest valve possible. So your valve-in-valve prosthesis can be the largest size possible. So things that we do, for example, in these rheumatics that may have some calcific invasion of their annulus, debride the calcification. The bulky leaflet, posterior leaflet, oftentimes I'll resect. I'll manage the geometry by reimplanting cords and secure them to the annulus and really try my best to implant the largest bioprosthetic valve that I can. We don't have a root enlargement technique like they do for aortic valves. So I think that's something that you really need to pay attention to.
Thank you. There's one question in the chat from Sherry Ramaroko, who asks, what age would be the cutoff? We deal with large numbers of rheumatic patients, mostly in the 30 years old age group. So that's a question to the whole panel.
Well, I'll start off. I mean, and I'll just refer to my last slide. I think a strict age should not be a cutoff, right? So if you have someone in their 30s and they want to have children, I would probably recommend a bioprosthetic valve for them. And again, understanding their lifestyle and their social determinants of health. So all those are factors. I don't have a strict age cutoff.
So, that is getting into the age where I'd be thinking about a mechanical valve, just because there otherwise be, multiple potential valves if you were always using tissue valves. And I'm going to talk in a minute about patients that, want to get pregnant. And so the choice of valve in that group of patients. But, I just have the conversation with the patient in terms of, their age is going to put them at risk for reoperations, et cetera, and potentially pretty early, although I'll show that data. So I think that a hard and fast rule like 70 or 65 or 55 or something, you're in this gray zone, in particular in their 50s and certainly in their early 60s, where I don't know that we need to be as firm as we are in the guidelines. The guidelines are just too prescriptive. At 64, you get a mechanical valve. At 66, you can think about a tissue valve. Life isn't that way.
Yeah, I agree 100%. I think those guidelines are rapidly going to change. Most of the data are based on valves that we wouldn't put in anymore. And most of the technologies that we put in now will be able to accept a valve-in-valve, which will extend the life of this valve. Who knows, 5, 10, 15 more years after their index procedures. So I think it's changing rapidly. I don't know where the bottom of the age is, but certainly down into the 40s, I think we routinely consider, biologic valve.
Thank you very much. So now we're going to move on to Dr. McCarthy's presentation, which is entitled, What's the Right Choice for a Young Patient with Endocarditis Who Wants Another Child?
Joe, let me know when you can see my slides.
Perfect. We can see.
Should be any moment now. Oh, Well, we're starting at the very end. So, okay. So this is a 30-year-old patient who has endocarditis, and she wants to have another child. And so this is actually a really interesting topic. This is something, it's kind of a niche. You don't run into this very often, but it's such a profound and important decision about what type of valve that the patient is going to get. And I hadn't spoken on this in many years. And so I was actually glad when they gave me this topic, because I needed to review the literature. Here are my disclosures. So what do you do in general with mitral regurg? Do you repair it or do you replace it, endocarditis or not? So the rule that I learned years ago at the Cleveland Clinic, good repair is best. If you absolutely can't get it, like in endocarditis, then replacement. But the worst is to get a bad repair. But this might be the situation where you fudge that a little bit. So if I thought that I could get a repair that is durable, but maybe there's a little mild to moderate afterwards, then I may opt for a repair. It's not often that you would have to do, a replacement even for endocarditis, but this is really one, these are complex. And this is, again, a patient where this decision is going to be so important for the rest of her life, potentially, or for at least the next 15 years or so. So what about a mechanical valve? So this is an older patient, or an older study, but I show it. It's from the Mayo Clinic, and this is looking at the risk of thromboembolism annually for repair or bioprosthetic valves, and it's twice as high with a mechanical valve, and 3% per year if you're 30 years old. And this is despite being on Coumadin, theoretically therapeutic doses. That adds up. As we would hear about it, it's going to be 100% risk at some point that a young patient is going to have a thromboembolic event. So then there's the PROACT trial. And so, are we going to be able to get by with a low dose of Coumadin in this group of patients? We already know that you can't use NOACs, and unfortunately, there was no improvement. So low dose warfarin did not achieve non-inferiority. So if you're talking to that 30-year-old patient, and if she wants to have a mechanical valve, you're stuck with Coumadin, and you're not going to really be able to get away from that. So this is a part of the review that I thought was interesting, because I hadn't looked at this in a long time. So these are the Society of Maternal Fetal Medicine. And so they were looking carefully at this issue. And so the literature shows that mechanical valve thrombosis is in about 5% of pregnancies. That's a big deal. I've taken patients to the operating room with acutely thrombosed mechanical mitral valves doing CPR. And, some of these may just be kind of a slow onset and a gradient's getting higher in symptoms, but sometimes those can be big disasters. The risk was lowest if the warfarin was able to be kept less than 5 milligrams, but a lot of times you're not going to know that beforehand. And here's the other part I didn't know: embryopathy in 30% within the first trimester. So this really is going to have implications for a young mother, and miscarriage in 24%. So you could think about low molecular weight heparin, but thrombosis risk is even higher at 4 to 16%. So the ACC guidelines say and note that there is no ideal anticoagulant for pregnancy with a mechanical heart valve. So if the patient is going to choose that, this can be a significant limitation during pregnancy. Yikes, as I said. So what about a tissue valve? So the concern, of course, with a tissue valve is durability. So Matt showed our data from the paper that we published in JTCVS. And so this is the overall data. It stratifies by age as expected. But the interesting thing about this is that none of them are all that high. You hear people say, well, a tissue valve is only going to last about 8 to 12 years, especially in young patients and stuff. That's not at all what we found. So here's the durability for mitral reintervention in the young group. the 30 to 39-year-olds. So at 10 years, it's about 25%. So it's not that tissue valves only last 8 to 10 years in these young patients. It'll last longer. There aren't a lot of patients that go beyond that to 15 years, but it didn't appear that there was a sharp upswing in these patients needing reintervention. So that's encouraging. So it does look like, at least in the majority of the patients, that it's going to last longer, but there are some that only go 5 years. So if I'm talking to a patient about this, and she needs this valve replaced, ideally, she will get on with her life and have her children sooner rather than later. So how do you manage the future valve choices? And I wanted to put this in a timeline for perspective. And Matt had talked about the 55-year-old. Well, it's important to remember the first mitral valve in valve was only 15 years ago, and this was just approved 7 years ago by the FDA. So if you implanted today a 55-year-old, the data would indicate that most of them are going to go at least 20 years or so. So at the very earliest, maybe at 15 years, they might need a reoperation or so. Or if they go 20 years, then you're going to be looking at 2044. So think of this, though, how quickly we have changed technology and evolved it and made things better. So, here we are today. It's only 7 years since it was FDA approval. And, to think that by 2044 that we're not going to have better options seems pretty unrealistic. So I'd be pretty optimistic. Well, what about this 30-year-old? It's the same thought process. It just moves it earlier. So the 30-year-old perhaps is going to need a reoperation sometime earlier, or maybe is going to go longer until they're 50 with it. We don't really know with that group of patients. One good thing about the group of patients in that pregnancy age range is that if they need a reoperation, it's typically elective. Maybe they're still 40 years old, hopefully still very healthy. And in that group of patients, the reoperation mortality has been as low as 1% or so in series from places like Cleveland Clinic, Mayo Clinic, and others, and even in our series that we had talked about. So the risk of a reoperation for a young, healthy patient that is just electively undergoing a reop, not for endocarditis or some emergency, is pretty low. And then otherwise, if it is 2044, let's see where we are with the technology, and then we decide. So this is pretty short talk, but basically for that group of patients, a mechanical valve is probably not a great option. A tissue valve just kind of kicks the can down the road in terms of what's going to eventually happen for their lifetime. But in the meantime, this is probably the safest way for most young women to have their valve replaced. Thank you.
Thank you very much. Comments or thoughts from the panel? And again, this audience, you're very welcome to write your questions or comments in the Q&A.
Yeah, Pat, I think you brought something up very interesting. Is obviously in that 30-year-old with endocarditis, a tissue valve is going to have early degeneration. Even in our series, the 30 years olds did not do as well as the rest of them. I mean, They have higher calcium turnover, and of course, pregnancy exacerbates that effect as the calcium turns over faster and faster. So I think we're all on this panel are going to do everything we can to repair that valve as much as possible. The interesting question you brought up was, we're all taught to say, 0 MR is what we'll tolerate. Will we tolerate a little bit more in that very special instance of a 30-year-old who has endocarditis and we're trying to repair it? And I think the answer is I probably would. I'd probably tolerate a little bit more because she won't calcify her own native valve as fast and so on like that. But that's a very interesting question you brought up.
Yeah, and I brought it up, Steve, with the same thought that, if it's endocarditis, that was an event, make sure they're on antibiotics from now on whenever they have their dental work, et cetera. But it's not like rheumatic disease that may be more progressive and that you're sort of anticipating that. And, you'll be talking soon about kind of the young rheumatic group of patients. But I would tend to kind of accept that. in that group of patients, as long as it's really not kind of an outrageous amount of mitral regurg. I mean, this is the only situation where I would do that, would be to tolerate a little bit more mitral regurg.
We've looked at our endocarditis, and I think we have the ability really to get pretty good repairs. Our, recurrent regurgitation rate is really low. We use a lot of bovine pericardial patch when we have to. Those will calcify.
Yep.
The patches will calcify, but if you use them judiciously, I think the results are pretty good. But again, I think if you can't do that, I think in this age group, a bioprosthesis, setting yourself up for later valve-in-valve, is a very good strategy nowadays. It's a real strategy.
Yeah, I agree.
I also think, Pat, one other comment on that is to just stress that not our study alone, but even in Joe's paper and other published, that you don't really necessarily pay a steep price for reoperation, even if you do have to replace them in the younger age. And so, we're all on the panel that also we'll repair these as best we can. But even if you do have to replace them, and at that time, a bioprosthetic is the appropriate choice for that particular scenario, you shouldn't really pay a significant price for reoperation.
Given the huge amount of variability, though, in the mortality associated with reoperation, you guys have obviously learned a few tips and tricks over the years. What's your approach to really make that a 1% mortality, not a 5 and above?
So I think a lot of it is patient factors, just sort of comorbidities. The second is that when I looked at the series from California that was high, I wondered how many of them were patients that had, like some underlying condition, like why did they get a tissue valve at age 45 when it's against the guidelines? Did they have liver dysfunction, or there's some other things that are outside what we measure with the STS? I think that contributes to what those outcomes were. And then the other is, I believe that they did not filter out endocarditis, as I recall that paper. And Joe, I'm not sure if you were able to in your study.
Yeah, we filtered out endocarditis. The New England Journal of Medicine did not.
Yeah, I mean, clearly endocarditis can change the situation pretty remarkably, but endocarditis can happen with a mechanical valve too. And so when you're thinking about making a decision with a patient, to me, it doesn't matter too much, because both of them can get infected, and that's just always bad.
I think there are some technical tips and tricks that people know about doing redo mitral valves. Make sure they're in the best medical therapy. If you have to bring them in and pre-treat them and diurese them and so on like that, do that. That's much better. I think there are some technical things, cannulating the groin if it's stuck against the sternum and so on like that people learn. One of the things in the big administrative databases is they did not look at, was this done at a center that does a fair bit of mitral surgery? And I think, mitral valve surgery, it should be done in volume, like many other things. The more you do with something, the better you are at it. But I think it's true that, we can serve the patients well in that the redo operation should be the same mortality as an index operation. And that's been shown in a lot of cases. Matt, thoughts?
No, I agree with you on all counts. And, I know how we approach these patients at Michigan, with some similarities and some surgical differences. Pat, do you have any technical things that you can share in terms of a reoperation?
It's overkill, but I always go with the safest option. And so I usually do have like arterial cannula in already, and a percutaneous femoral vein cannula. Early on, I was using femoral artery and then axillary after a little bit, but it doesn't take very often when you're not cannulated and then you saw in and, there's a tear in the right ventricle and you're kicking yourself. If you're already prepared for it, then it's pretty easy to go on bypass and then get that repaired and turn a catastrophe into a manageable situation. So that's probably the safest way that I would approach it. And then I think just with experience, as Steve said, there's just tricks about exposing those valves, because of the adhesions, they can be difficult to expose. So I always take down the apex and I really let the heart fall down. and that rotates the valve and makes it a little bit more visible as you're doing it.
I
You
think
used
one,
to go,
I think one good
transeptal
trip
and
is to
Romano.
do them through a thoracotomy. I do a lot of right thoracotomy redos. You don't really have to do too much problem with the adhesions. It's a great, you know, if you have an aortic valve in there, it's a great way to look at it. I like a right thoracotomy for a redo. It's a good technique to learn.
Matthew?
Oh, I was gonna say, yeah, when I do it through a reduced sternotomy, I don't know about you, Pat, but I have found going transeptal really helps your exposure. You mentioned taking down the apex, which is, I think, very important. Sometimes when there's so many adhesions, I don't spend the extra time doing that, but I feel that I get really good exposure by going transeptal.
Okay, so our next presentation is going to be Dr. Stephen Bolling, who I think is going to educate us on the
So I'm going to
rheumatic. What
share.
is the right choice for a young patient with rheumatic disease?
Yeah. I'm going to share my slides now. Can people see my slides? No.
They came and went.
They did come in once. Let me try that again. I got assigned. They're up now, right? Yeah. I cannot see them right now.
So we can see your slides.
Oh, there we go. Can we see them now?
Yes.
Good. So Matthew was assigned a 55-year-old and Pat talked about a 30-year-old, and I got assigned right in the middle where I think it's very most controversial. This is a 45-year-old with rheumatic disease. They, of course, present at that age with both mitral regurgitation and significant mitral stenosis. And the question is decision-making with this patient, what to do. Do we try to repair them? Some can be repaired. Should we replace them? If we do replace them, do we put a mechanical valve or biologic? Obviously, now we talk to the patients. It's fair to talk to them about a valve and valve. But most surgeons are just driven crazy about this patient. Just decide for me. Tell me what to do. We want help to make that decision. So this was our series. We presented a couple of years ago at the AATS where we had two eras, one in the 90s and one third in the early 2000s, about 200 patients, where in the first part, we tried to repair almost everything. And then in the second part, I think we got smarter and we looked at guided decision-making, looking at more, if the anterior leaflet would stiff, we would go ahead and move to replace the valve. These are the outcomes. You can see in our second era, 10-year era, our mitral valve repair rate actually went down to about 33%. We were repairing twice as much that in the first era. We did a lot of techniques in that first era. But interestingly, when we did replace these patients, over 90% of them were biologic valves. The overall age was around 60, with some of them much lower down into the 40s. And this was interesting. This was a shared decision with the patient. This is what they wanted. So this was almost all of these patients were against the guidelines. You can see, however, this survival in the second era shown in pink was better, that our plan of repairing only selectively and replacing with the biologic valve actually ended up with better survival in those rheumatic younger patients. At that time, a number of other papers were coming out too, looking at, so this is Joe's paper on the left, looking at biologic versus mechanical, that biologic did pretty well down to age 50. And then other ones, Larry Cohn's series and a series from here from Michigan, looking at the choice of tissue valves in younger age groups, below 60, below 50 even. And was that it? And at that point in time, my kid, Pat, he called me up and he said, like, Steve, I'm confused. We were all confused. He said, you know, Matt, let's do a study. And what ended up was the study that Matthew presented. And I'll just present a little data of it. It was very interesting to us. This is 1,500 cases that in this group of valves, in this group of patients, the degeneration rate, the mortality was very, very low, surprisingly low. If you looked at it by age again, The only group that really stands out was those between 30 and 34. The 35 to 39 was a little higher, and then all the other age groups sort of clumped together. If you look at it, we used to think that this was strictly a linear factor, that a 30-year-old would do worse than a 40-year-old, that would do worse than a 50-year-old, and so on and so forth. But if you look at this bucket plot, we plotted it by 2-year age groups, 3-year age groups, 4 years, 5 years clumped together. You can see that there's a very flat degeneration rate, that a 40-year-old doesn't degenerate any faster than a 50 or any faster than a 60-year-old, that this is a sigmoidal curve and not linear. You can think of it this way, that we used to think it was an absolute linear function of age, that a 20-year-old did worse than a 30-year-old did worse than a 40 in terms of valve degeneration. But in this study, that was shown to be not true, that there's a very flat part of this curve between 40 and 50 before it rises up to the younger age group. So I think this study opened a lot of people's eyes to think that you don't have to be 65 or 70, as in the European indications, to say this would be reasonable to put a biologic valve in. In that age group, and in this particular patient, a 45-year-old, I think it's very reasonable, speaking with them, to say, I'm going to put a biologic valve in, and the degeneration rate is really not going to be that bad at all. If you look at this, looking at the age of 40s and up versus all the other age groups, there's no significant difference in terms of time to degeneration. Matthew put this slide in. I love it. This is, warfarin is a rat killer. No one likes Coumadin. Patients just don't want to take Coumadin anymore. And even the mini Coumadin trial was not good. Eliquis, Xarelto was an absolute disaster. The NOACs and mechanical valves, for most anticoagulation, it's a balance of clotting versus bleeding, but somehow all the NOACs seem to have both elevated bleeding and elevated clots at the same time. And 2 large series have been stopped early, and those are disaster. And like Pat mentioned, there is a 3% or even a 4% in study, a linear rate of events on Coumadin. It's just math. So if you take a 45-year-old and you put them on Coumadin and you want them to live their entire lifespan to age 82, you have a 100% chance of having some type of thromboembolic event for this patient. It's unavoidable. So one of the things that we also looked at in this group was the reoperation rate. Mortality was the same as the index. And that, as Matthew pointed out, compares against what we used for our guidelines, which was a 14% reoperative mortality, which was extremely high, 3 times higher than what was shown in this study. I think we also have to really take into consideration valve and valve. When we implant a bovine valve, these patients do not die suddenly by tearing the valve. Now, both porcine and bovine valves definitely calcify, but the mechanism of calcification for a pig cardiac leaflet is calcification and then sudden tearing. So these patients usually present with sudden and torrential mitral regurgitation. It can be catastrophic. You may not be able to get them to the cath lab or the operating room fast enough. Whereas a bovine valve slowly stenoses over time. This is a patient you can see with a bovine valve. 2 of the leaflets are frozen. 1 is still opening. This patient came into my clinic and we decided we're going to mount a valve and valve. When somebody asks about what do we think about now when we put a valve in, well, we think about valves that we can see on fluoro. All the valves in our study were paramount. You can see them all on fluoro, and it really helps actually to be able to see the entire stent frame, to be able to mount this without getting it too atrial, without getting it too far out into the left ventricular outflow tract. Also, you should think about putting the largest valve that you can. We want to use an upside down TAVR, probably a 26 or a 29. We find that the 23s, if we put those in, they get probably a high gradient relatively quickly. You can see that the valves that we use now, which is the mitral valve, have a very large orifice and are able to accept very large TAVRs. So valve and valve actually is a very viable strategy for this patient. And you can see what we did in the patient. You can see the result is very nice, has no left ventricular outflow tract and so on like that. Final result, very good orifice. So we looked at our mitral valves together. We have about 173 patients. SDS prom for redo is about 5%. The 30-day mortality is 1%. We're now looking at long-term follow-up of these patients. We don't know how a mitral valve will last. Will it last 5 years? Will it last 10 years? Will it last 20 years? We think it would last. We've been doing them for 7 or 8 or 9 years now, some before they were approved, and we haven't seen any cliff where they fall off suddenly. So we feel that these will actually have probably about the same length in the patient before they start to stenosis as the same size bovine valve. So I think Matthew showed these. You know, if you're over 65 in American, you should get a mechanical valve. If you're over 70, I mean, you should get a bio valve. If you're over 70, you get a bio valve. Well, I think those should go out the window. And I think this is me now too. There should be no age cutoff, that there's a lot of things, age, comorbidities, lifestyle, anticipated other surgeries, pregnancy, and so on like that. Again, we don't live with the decision, the patient does. And I think I'll use this as the concluding slide before we go to discussion, that this is the most important thing. This is lifetime management of a valve disease. Obviously, when we see someone with degenerative disease, we repair that and we've cured that of their disease. Once we get to a disease state or a different disease state where we have to replace them, we have to be smarter, because now we know they're going to come back for something, and we have to think about lifetime management of disease. So for a 45-year-old patient, I think we're quite justified to be able to say, we can put a bioprosthesis in this patient and expect it to last quite a long time without valve degeneration. And our next step to set ourselves up for success is put the type of valve in there that we can put a valve in. Thank you.
Thank you. That's absolutely terrific. And I want to make sure we've got time to answer questions. One of the questions that got typed into the chat, struts. Can you just walk us through how you orientate your struts so that there is no LVOT obstruction at the end of the case?
Yeah, I'll take that. So struts should be at, what we think of as 10 o'clock and 2 o'clock, although it's not exactly that because the aortic valve is not straight up. So when I think of it, I probably put the struts at about 9:30 o'clock and 1:30 o'clock, and that's it. And if you ever do an aortic mitral, it's very nice to put the mitral in and look down there. The aortic valve should be cupped by the struts. There should be no outflow obstruction. Obviously, there's going to be the lower strut, the single strut, which is down, so to speak, at 6 o'clock. That's how I want to orient it. And that will give you the least amount of outflow tract obstruction.
I think the only thing I would add to that is I think this is where surgeons need to educate themselves and pay attention to the different valves out there, and look for valves that have the shortest struts, especially in the mitral position. The most current generation of valves really are focusing on that. And like you said, Steve, I usually look to put the strut in the anterior lateral commissure. If I pretty much align it that way, you're really unlikely. Also, you can consider doing a myectomy or an alcohol ablation if that's a consideration that you've seen on your preoperative imaging, like on a TEE, and you say, geez, I have a pretty generous septum. You may consider doing some type of septal procedure, either preoperatively or intraoperatively.
I think that's a really good technical point, Matthew. Often when I put all my stitches in, I will mark which stitch, which I put in my little holder there, is at the anterolateral, or me as a surgeon, that is my left-hand commissure. All the modern day valves are now marked with a spot where they think the aorta should go. And I take that stitch that I put in that commissure and I start right there in the anterolateral commissure, and I know that's going to go down in the right position. So they've marked these where they think the aorta should go, and I mark my left hand or anterolateral commissure lateral, and I put it through there. That is the first stitch that I put into the sewing ring.
Yeah, when I do a mitral replacement, I have my heavy pickups, the Romanos, and I'm pulling the anterior leaflet down, and I make my incision at the base of the leaflet. And the first stitch I put in is at that anterolateral commissure. That's where I start. And I mark that one separate. So I know that is the stitch that I'm going to line up. And I agree with Steve, 95% of the time, it almost looks like 10 and 2 o'clock. The only other thing that I do besides what they've mentioned is that way back in Mayo in the 80s, I learned to use the dental mirror in there, and you can get them now that they're kind of flexible, so you can really kind of turn it, and then also it's magnified. And so I put the dental mirror in there too, just to double check and triple check and make sure that there's not some weird orientation of the aorta. And that, kind of helps me. But honestly, if you put the stitch at the anterolateral commissure through the post, I think 99% of the time you're going to be fine.
That's a great answer from all of you. It's super helpful. One question in the chat, what do you think about the different durations or time to calcification in porcine versus bovine valves? We'd already talked about the presentation with MR, but is anti-calcification methodology making a difference here, or is it really about bovine versus porcine?
Well, let's put it this way. Part of the reason that we wanted to do this study is that I've had to talk before about bioprosthetic valves, and Steve and I started talking about it. There isn't a lot of data out there about the durability. And so I would love to see a very similar study done with porcine valves because a lot of them are kind of older studies and, they don't have very many young patients in them. And also I'm definitely not the one to discuss the chemistry of calcification of the leaflets. Maybe Matt is, but it's just an area where there hasn't been enough published yet. And so we were only looking at bovine pericardial valves. So I don't really have a good comparator to porcine valves.
I mean, I don't know about the chemistry. I mean, I know a little bit about the chemistry, but I mean, obviously the anti-calcification has gotten better and better and better. And I wouldn't say anything that I'm sure they're using it the same in the porcine valves. I'm sure they're fine. It just that hasn't been studied. This is purely a study of bovine because our institutions, favor, bovine pericardium. I like that the stent legs on the bovine ones tend to be slightly shorter and don't stick out into the aortic outflow tract tube. So that's one of the other reasons. I think the two reasons that I favor bovine over porcine is the strut legs are slightly shorter and that the failure mode of a bovine is never catastrophic, not never, but it generally is not mitral regurgitation and it's slow mitral stenosis. These give the patients a chance to come into medical attention. You go ahead. The other thing is, Pat's right. There haven't been very many pure follow-up studies of a particular type of valve. Most studies are some of this and some of that and some of this. And it's very hard to draw any conclusions. So we decided, we have 1,500 of basically the same valve. And actually the structural deterioration rate is surprisingly and happily low.
The only thing I'd add is I'm cautiously optimistic. Edwards has their Resilia platform on their current both aortic and mitral bioprosthetic valves. In their juvenile bovine models, there's significantly less calcification. How that translates to long-term, we don't know yet, but there's ongoing studies both in the aortic and mitral position, and I think they'll be very informative as we get long-term data with the new preservation technology.
So there was a question also about aortic valves and whether the guidelines ought to also be a little bit more squishy, give a little more room. It really is all about the patient's decision because they have to live with it. We don't. So I would agree with that. I think that all the guidelines should say there's multiple factors that we should discuss with them. But, I think what the important thing of this is that, Steve and I are same generation. We didn't really pay attention to the guidelines. The only reason that we have this data is that, patients would come to us at age 45 or 50, and they would say, I'm coming to you because I don't want to be on Coumadin and get a mechanical valve. And everyone has been telling me that's what I need to do. And so the guidelines are guidelines. They're not rules. Nobody put handcuffs on Steve and I because, we did what the patient wanted and it seemed kind of realistic. And the early data was looking pretty good. We didn't have as good a data as we do today, but that's why the guidelines get moved.
Well, exactly. They're right. I mean, the guidelines get moved, the guidelines get changed because somebody violates the guidelines. Right. So that's exactly how new lace. And I think that's okay. I mean, if you think of it judiciously and you're careful about it and you talk to the patients, I think this is how guidelines get changed. And I think it's exactly this data that will be analyzed the next time around the guidelines are made. And I think they're going to move it down. And if you said, gosh, everybody loves a number because the number is easy to point at and say so, but I would say, it should be 60 or 55, it's quite justifiable, or even 50. Those are the kind of things that this data supports.
We talked briefly about anticoagulation. Are you anticoagulating your patients with new bioprostheses if they don't have other indications for anticoagulation?
I do. I think, the ACC, AHA guidelines say 90 days of Coumadin. I think that, until the valve settles in, there's an incident of halt, this subleaflet thrombus and so on like that. So unless there's an absolute contraindication to anticoagulation, I follow the guidelines on that until somebody tells me the guidelines are not right. So I put them on for 90 days.
Yeah, I do the same. And, if you did have to reoperate on a patient at 30 or 60 days, you'll see that the endothelialization is not that secure. And I feel better having them on a, low dose of Coumadin, 2 to 2.5 for an INR for the 90 days. For the patients with atrial fib, we just published, we're doing 100% concomitant ablation and we close the appendage. So for that group, they're on a protocol that they're going to be on Coumadin for 6 months. And so, but then we're doing regular checks of the rhythm at 3 months and at 6 months. And we stop the amiodarone if they're on it at 3 months, make sure it's washed out. And so we want it well documented that the patient is out of atrial fib before we would stop anticoagulation.
Right. We do the exact same thing, Pat. 100% maze, basically take the appendage and so on like that. And at 6 months, we actually get a 2-week monitor to look at their rhythm at 2 weeks before we will stop the Coumadin of that patient. But in the patient who's in sinus rhythm, I do it for 90 days and then I stop.
So that's absolutely helpful in terms of insights. We've really reviewed the literature today that generally supports a lower age consideration for use of bioprostheses. This is based on the extraordinarily low rates of reoperation in even quite young patients, improved valve durability, the safety of reoperation, and the advances in the transcatheter valve in valve space. I'm curious to hear your wrap-up comments before we hand back to John.
Well, I'll start the wrap up by saying thanks to Edwards. It's through, webinars like this that this type of knowledge is transported all around the world. And I'd like to say that, it's really a lifetime management and you don't live with the decision, your patient does. So really talk to your decision. One 55-year-old and another 55-year-old will not be the same person, and make that decision tailored with them together.
Yeah,
So I guess what I would say is that, Steve and I have been around for a while and the field evolves. And that's why I use that timeline looking forward to 2044. Think of what can happen between now and then. And so, it really is constantly changing. And so, really consider what the patient will be wanting and, being committed to Coumadin every day the rest of your life and that risk for a stroke is something that personally I wouldn't want that. So I've been saying that since I was 40. So and also thanks to Edwards.
The only thing I would add is I agree with everything. I think we're so quick to want the easy answer and to look at a guideline or a piece of paper to tell us what to do. But this, I think, is really important, that we need to just think broadly. And echoing what you said, consider the patient as a whole and not just focus on what is written in the guideline to totally make your decision.
So all 4 of us as surgeons that are well below the age of the guideline cutoff, we're not going to fight over who's the youngest on this call, but all I can say is if God forbid you can't repair my valve, I'll take a bioprosthesis pretty much any day. John, back to you.
Thanks, everyone.
Thank you for attending this Edwards Life Sciences webinar held in collaboration with CTSNet. As a reminder, a recording of today's webinar will be available next Tuesday on ctsnet.org and CTSNet's YouTube channel. Have a wonderful rest of your day.